All right, this will be the second half of the COPD lecture that was interrupted suddenly. So we'll get back into, we were with gold guidelines, I believe is what we're talking about here.
Negotiators to respond immediately to the
no, I don't need that anymore. Okay. Hit the wrong thing. I'm just going to silence my phone. All right. Sorry about that. So gold guidelines. Went through everything on the right. I was drawing the diagram talking about how to incorporate these letters now. We have our two axes with FEV1 on the left-hand side, exacerbations on the right. Down along the bottom, that's what I was working on. What goes down here, this is symptoms. So over in this column, less than 10 symptoms. Again, I talked about there's different criteria for that. You can look at the CAT or the MMRC assessment tools that you can use for symptom and symptom severity. So if there's less than 10, you're over here on the left side, and more than 10, you're on the right. So basically what you're doing now is you would take somebody's FEV1 corresponding stage. You'd come across then with symptoms. So say that they were a 2. So that FEV1 is between 50 and 79. So there'd be a 2 over here, but say they had 10 or more symptoms. That's going to shift them over here to a B, right? And then we're going to look at exacerbations. If they've had 0 or 1 in the last year, they would stay in the B. Or if they've had 2 or more in the last year, that's going to bump them up into an A. So that's essentially how that works. It was a lot easier before they added this this letter stuff. But anyway, you can read the gold guidelines for what the letters represent. But that's basically what you need to know in terms of classification of severity of airflow obstruction utilizing your gold guidelines. So let's go ahead and just move right along. So let's talk about treatment in the setting of COPD. Now, we have already covered that in the previous lecture talking about inhalers. That was specific, though, to the bronchodilators and the different inhalers. So you can look at that lecture. I'm not going to rehash all of that, but we know that we have our bronchodilators and the various classes which have already been covered. We have oxygen, right? Kind of important in the treatment of COPD. There are some limitations, of course. The main goal with oxygen is to maintain SATs greater than 90% in the setting of COPD. Because keep in mind, a lot of these people already exist in a hypoxic state. That's kind of where they hang out. That's their baseline. They aren't. They may hang out at 87 or 88%. That's why I find a lot of times, especially in the primary care setting, when I have students doing clinicals with me who come from critical care and ER background, somebody comes into the clinic and they have an O2 sat of 87%. You guys are freaking out and are wanting to start doing invasive stuff. You're wanting to, you're looking to, call respiratory to come in and do an ABG. You're all, but look at the patient, treat the patient, not the paper, right? So keep in mind that a lot of these people walk around in a hypoxic state, and that's where they hang out. You get too much oxygen, that's going to be bad for them. You don't want to oxygenate these people to 100%. They're going to cause a lot of CO2 retention, right? So keep that in mind. Always look at the patient, treat the patient, not the O2 sat. If someone comes in when you're doing clinicals, don't freak out unless they're in acute respiratory distress. But hopefully those people have called 911 and they're someplace else other than where you're at. But the main thing to remember with oxygen is that and it gets we'll say it gets a gold star for this because it improves survival. Which, that's a good thing, right? So if they are a smoker, we want to provide them with tobacco cessation or smoking cessation utilizing the 5 A's framework. You need to consider pulmonary rehab, referral, A lot of these people can't do it on their own. They need a little help. Talked about in that 1% of people who have the alpha-1 antitrypsin deficiency. So if they have that, you're just simply going to treat with replacement. You're not, pulmonology is, but you kind of need to be aware of that. And then the primary outcome, or the goal of treatment, our goal is going to be a decrease or reduction of symptoms, right? And also we want to reduce the risk of future exacerbations. So those are some hallmarks to remember during the treatment of COPD. Keep in mind that symptom reduction and risk reduction is very important. So if you were to, and the reason why, if you were to look at it, so if we're talking about symptom reduction, we're wanting to relieve symptoms, right? We're wanting to improve exercise tolerance. And we aren't talking about, again, training for a marathon. We're focusing on ADLs. And we want to improve their overall health status. So those three things are examples of symptom reduction. So if you happen to see on a test question, all of the following are examples of symptom reduction in COPD except, you know that these three are, so whatever the fourth thing is, that's not going to be it. Same thing can be said for risk reduction. So what we're doing with that, the three hallmarks of that, we want to prevent disease progression. Sorry, as you can see, my handwriting takes even more of a nosedive and gets even worse after I've been on a SWAT call out. We want to also prevent and treat exacerbations. And then we want to reduce mortality. So these three are examples of risk reduction with COPD. So again, if you see that in the future on a quiz or a test, there you go. Other things that you want to consider overall in this whole grand scheme of treatment and reducing symptoms and decreasing risks of future exacerbations. Things you want to be considering is, of course, you want to make sure that these folks are getting vaccinated. Influenza and pneumococcal are paramount in this subset of patients. You also want to be assessing inhaler technique regularly. Make sure that they're actually getting the medication that they need. See a lot of COPD exacerbations that can be prevented simply by taking the time to show somebody how to use a meter-dosed inhaler. Don't think that the pharmacist or the pharmacy tech is going to do that. They actually do a shockingly poor job of doing that. You know, they just like to hand you your sack of whatever with a 10-page printout of all of the different side effects and stuff like that, and expect people to read that, and that goes straight in the trash as soon as they get home. I actually have a handout that I give patients that I'm starting off on any sort of meter-dosed inhaler for the first time. First off, I typically will have, I will demonstrate in the exam room, and then I will have them return demonstration and have them give themselves a first dose of whatever I'm prescribing, if I have a sample of it, that is, in the exam room. If not, I take the time to at least teach and educate them and give them go through the steps and have a handout that goes through step by step how to use a meter dose inhaler properly. So that's key. You'll see some stuff out there in terms of, okay, I can't talk my patient into giving up the cigarettes completely, but hey, they are willing to do an e-cigarette. There's absolutely no data out there right now that shows any efficacy of e-cigarettes in terms of a reliable smoking cessation mean in the treatment of COPD. So keep that in mind. So basically, overall key points in treatment of COPD is going to be you're coming up with a management strategy that's going to keep them in a stable disease status. Again, all individuals who smoke need to be strongly encouraged and to give them support to quit. Again, main treatment goals, reduction of symptoms and future risk of exacerbations. And then also keep in mind that your treatment modalities are not limited to just pharmacological treatments. You also have other complementary non-pharmacological interventions. That's mentioned up here most prominently, pulmonary rehab. So just remember that. So as we continue on and kind of get towards wrapping this up, let's talk about managing exacerbations. And for our purposes, we're going to be concerned about outpatient exacerbations because, again, that's where we're going to be treating this, where we're going to be seeing this. And again, this is family nurse practitioner, not acute care nurse practitioner. So we aren't dealing with a hospitalized patient. So we're dealing with this in the outpatient setting. So this is within the GOLD guidelines. If you have it, great. If not and up to date, here's your treatment algorithm for outpatient management of exacerbations of COPD. So you can see it branches off into two separate things here. There's mild and there's moderate or severe. Moderate and severe basically are considered the same. So you're looking for three cardinal symptoms: increased dyspnea, increased sputum production, increased sputum volume, and increased sputum purulence. So if they have one of those three, and that's it, then your treatment step is primarily supportive. There's no antibiotics. You're going to increase the bronchodilators. You're going to step them up according to what we talked about in the inhaler lecture. And you're going to have careful follow-up precautions and have them report any worsening symptoms, progression of symptoms that require them to come back. I typically will have these folks come back within about 48 hours just to lay my eyes on them and make sure that they're doing okay. You can't always rely on them to call or do the right thing. Now, if they have two of the three cardinal symptoms that we covered, and then we kind of branch off into whether we consider them to be uncomplicated or complicated. This gets into risk factors. So it's considered uncomplicated COPD if they're less than 65 years old, that FEV1, not the ratio, just the FEV1 by itself is greater than 50% of the predictive. So these are going to be your ones and twos if you were to go back up and look at the GOLD criteria. Less than 2 exacerbations a year. And they have no comorbidities, no cardiac disease. I'll talk about comorbidities here in a moment. and the key ones to look out for. Cardiac is always a hallmark. So if that's the case, then you're going to put them on an advanced macrolide, azithromycin, some zithromax. A lot of people do a Z-Pack. I find that tends to be too little of a dose over too long of a period of time. I like to hit these folks hard. Instead of doing the 500 on day 1 followed by 250, that's in a Z-Pack, I'll go ahead and put them on 500 milligrams, and I'll have them do that for a full 5 days. And there is data to support that, but you can go with the Z-Pack and be fine in doing so. Or you can go with clarithromycin. You have other options in case they have a macrolide allergy, or you can go with a cephalosporin. You have 3 choices. If you notice that we aren't talking like first-gen cephalosporins, and if, say, they have an allergy to that and they can't tolerate that, you have Doxy. Doxy has a real good lung penetration. So you're looking at a dosing there of like 100 milligrams BID for 10 days. Or you can actually do Bactrim. That's at the very end. So if you're in clinicals, once you get back into the clinical setting and you see somebody who's prescribing Bactrim, okay, but they really should have contraindications to all of these above. Just not the best lung tissue penetration with Bactrim. But anyway, so that's uncomplicated COPD. So if we have complicated COPD, so that just means one or more of the following. If they're over the age of 65, they automatically win themselves this treatment modality. If their FEV1 is less than 50% predicted, so that means they're a stage 3 or 4, they've had 2 or more exacerbations in a year, or they have any underlying cardiac disease, you're going to hit them harder in terms of your antimicrobial therapy. You're going to come out swinging with a big gun fluoroquinolone, moxifloxacin, which is Avalox, or Levaquin. Got to be careful though in the elderly, because we are dealing with patients greater than 65 years of age, so you have increased risk in that population, especially with underlying cardiac disease of QT prolongation and tendon rupture in the very elderly. So that's why it gives you the option to consider amoxicillin with clavulanate, which is Augmentin. That's typically the way that I go, especially since the manufacturer of Levaquin and Avalox came out with a warning to not prescribe their drugs unless they are not as first line anyway. If there are other options to do that first, I'll post that. As a matter of fact, hasn't quite, still here in the guidelines, but anyway. If you think someone has Pseudomonas, that's going to be someone who basically has advanced interstitial lung disease with COPD. Then you can just consider just believing it or not, just plain Cipro. Make sure you get a sputum culture. And then you can see down here as well that you also, before you stick these folks on antibiotics, you need to consider getting, if you can, have them hack you up a sample that you can send off to the lab for sputum culture and gram stain. So again, that's your outpatient management of exacerbations of COPD. We aren't concerned about inpatient right now. So cardiac disease, that's the main highlight here for comorbid conditions, and depending which way you go in your treatment guidelines. Other things you need to consider in terms of comorbidity, specifically with COPD, any recent respiratory illness, osteoporosis, depression, anxiety, are often underdiagnosed and associated with poor health status and prognosis in COPD. The osteoporosis because of steroid use. Obstructive sleep apnea. That's important, right? When patients already aren't getting enough oxygen as they should. If they have sleep apnea, we're just adding more fuel to the fire. So you need to look at that. GERD. We talked about GERD with asthma. Same holds true with COPD. And in general, you just need to assess for the presence of any comorbidities that could have a significant impact on the course of the disease. So basically, in terms of your management, some overall key points. The most common cause for all this, by the way, is going to be respiratory tract infection. That's usually what sets them off, because an exacerbation of COPD is typically defined as an acute worsening of respiratory symptoms that result in additional therapy, and usually there's underlying bacterial infection that's causing that. So we're going to give our bronchodilators that we've already talked about. You can give systemic corticosteroids. We talked about that in a previous lecture. They do actually improve lung functions, primarily FEV1 and oxygenation, and data shows that they will actually help to shorten the recovery time. But duration of therapy is limited to usually no more than 5 days. We used to put these patients on a prednisone taper. We'd start them off and we'd taper them down over a 7 to 10 day period. Basically now the standard of care is you stick them all on prednisone, 40 milligrams a day times 5 days and done. So you come out of the gate swinging, hit them hard, open everything up, help with the bronchodilation, and then you're immediately done. Of course, unless there's a contraindication to giving systemic corticosteroids, you have to look out for that. Antibiotics we've already covered, and that's pretty much it. So some things to consider in terms of if we go from outpatient or worsening. It says here worsening or an adequate response in 72 hours. Then we need to consider sticking them in the hospital, right? What you're looking for when you bring those patients back, and what you would be considering in terms of an adequate response would be sudden worsening of dyspnea, especially at rest, high respiratory rate, or tachypnea. Decreased oxygen saturation from their baseline, lethargy, confusion, drowsiness. If they have any new physical signs, central or peripheral cyanosis, peripheral edema. If they develop a new arrhythmia, that's why cardiac's so important on there. Or if they just have insufficient support at home and just can't manage or care for their disease. So those would be indications for hospitalization. So that's pretty much going to do it in terms of COPD. So we've covered asthma now. We've covered medications used both in the treatment of asthma and COPD. And now we have a two-part lecture on COPD because was interrupted. Hope you guys find this helpful. As always, any questions about any of this material, please email me. You can text or call. We can go over it in some more detail, but hopefully this gives you some idea of what you're kind of focusing on with your readings, maybe make some more sense of your readings. And of course, if I'm taking the time to talk about it and write it down, then there's a good chance you may see this again sometime in the future.